Good morning from Harbin. It's us three again. So let me briefly introduce the operator today. Dr. Sun Qingfeng, second operator Dr. Wang Haijun, and me myself. My name is Qingyun Zhou. I'll be the moderator today. So next slide, please. Today we are having the 85 years old male with hypertension and presenting to us with left lower limb rest ischemia pain, which is rated as the Rutherford force. And he is a smoker, and after being hospitalized, he is taking aspirin and statin. For physical examination, he has muscle atrophy for both lower limbs, and we cannot feel the pulse, and the foot is quite pale. For the ABI, the left pope is 0.5, and both AT and PT are 0. Next, please. And these are his CTA before operation. We can see the disease is mainly focused on the left external iliac artery, right? And also there's some disease on the SFA. But the collaterals are quite good. And if we zoom in, we can see a lot of calcifications in the iliac artery, and also we can see some calcification for the SFA. So I think Dr. Sun, today, if we considering about the current medical condition, which is rest pain, so the ideal condition is opening both the iliac artery and SFA, right?
Yes, it's okay.
Okay,
It's
but
the first choice.
yeah, the first choice and also the best choice. But for any time, we have to considering the patient's require and willing. So for these patients, after we discussed with the family, and they decide uh, to treat the iliac artery first this time, at least for this time. After that, we considering the collaterals, we can see the collaterals is building up very good. And so we suppose that if we open the iliac artery, it will greatly relieve the symptoms for this time. But if it's not working, we can try again to open the SFA for the next time, right?
Yes.
So I think this will be our today's strategy. Next, please. And the same for the last case, and we will use 6 and 8F long sheets for the vessel access and crossover. We have bunch of glide wires, V18, command 14, glide wire, stiff glide wire, and we are also prepared for using balloon for the PTA, and for the iliac artery. For our experience, there's mostly are stenosis and also thrombosis, right? So for the safety course and also for iliac artery, if we're using the BMS, if we post dilation too hard, the artery probably will break and perforation. So for the safety case and also for the thrombosis, like we prefer the Viabahn for the treatment of the iliac artery. Okay, so next let's go through some angio before we getting started. There you go, and yeah. This is the we can see the access for the right common femoral artery, which is of course is pretty good. And next we are going forward to the aortic, and you can see a lot of calcification for this gentleman. Of course, considering the smoking history, considering the age, which is not very surprising, but also bringing us a lot of trouble for treating this kind of patients, right? And next, this is the roadmap. After that, we are crossing over. You can see that we are using a pigtail to cross over, and glide wire, and this is the close look for the disease for external iliac artery. This is we are using guide wire to passing the disease, and you can see here there's some resistance here. But for most of the disease, we are crossing it pretty good and easy. So we are considering it might be some a short segment of stenosis or occlusion, and after that there's a generated some thrombosis, and that's what we are how we decide the next the final treatment. And okay, push a little bit, and finally we're going to the other side, and we push forward for the catheter, um, and I think there's an angio. Also, we are tracing the long sheath. But when we go into here and there's some resistance, we are considering this is the CTO disease part segment, and we'll leave the long sheath over there. And after that, we are using guide wire going to the SFA. And here we got some resistance. You can also see the calcification, which is the disease there. And we do try some, give some effort to trying to going past the disease, because although the collateral are pretty good, but if we have a good, healthy SFA, which has more outflow, which is good for the stent,
Yes.
right? We can last a bit longer. But of course we tried a lot, but you can see that for the SFA there, SFA alone generates a lot of collaterals, which is a good sign for us. We tried a lot, and we use mostly we are using glide wire, and unfortunately we cannot pass the disease, which is the fibrinosis cap is very hard. And considering the patient's situation and the opinion of their families, we will leave the disease at SFA for there. And this is, I think, this is the verification of we are going to the true lumen, which is we can see that the long sheaths have already going to the true lumen past the disease. And after that, we slowly pull back the long sheaths a little bit, and we give a little bit of dye, and we can see the distal fibrinosis cap, which will help us to locate the disease, and help us to choose the right size, diameter, and the distance for the stenting, right?
Yes.
And I think that's what we are right now. And so for right now, we are having a supercall wire in the vessel for the support. And well, next step, we are going to change a 8F sheath for the Viabahn through. And I think for now for I think people mostly interesting question is debulking for basically anything. If we can debulking first, we can use different methods to debulking. And Dr. Sun, what do you think about the debulking strategy for the iliac artery? We've seen a lot of people around the world doing debulking for the external artery or common iliac artery. What do you think about this? Do you like debulking method for the iliac artery, or do you planning using this for this case?
No, because I think it may be the stenosis is based on and the thrombosis.
Mm-hmm.
Maybe the booking is very good,
Uh-huh.
but
Definitely.
this case
Uh-huh.
is high calcification,
Yes, sir.
and
So they might be
iliac,
dangerous, right?
dangerous. So
Okay.
I think maybe stent graft is okay for
It's
this case.
okay. So yes, indeed, considering of course, debulking is very advantage, a very modern idea for the vessel preparation right now. But actually, we are quite cautious for using debulking method for the eternal for the iliac artery, because if the senior patients have a severe calcification, and because of anatomy of the iliac artery, there is no actually. It's not like lower limb. You have a lot of muscle around the vessel, which if it's a perforation, you can also have the muscle to compression to stop the bleeding. But for iliac artery, you have just your organs in your pelvic, your abdomen, so which is quite soft. And if it's perforation, it's very hard to stop bleeding. So for the safety case, we usually don't use debulking or Rotarax, whatever, to for the cell preparation. And next, after we successfully changing the sheaths for 8 French, we are now measuring the diameters of the blood vessel. But there's a different methods for uh, measuring the blood vessel, for choosing the right size of the stenting. Of course, you can do it for the CTA, which is more like us, right? We measure the blood vessel before the operation, so we can have a fully prepared operation going on. But you have to uh, uh, measure the exercise in the during the operation. So here we are using the a balloon with a marker from BD company, and
Ultrasound, ultrasound,
uh,
ultraverse,
Ultraverse, yeah,
ultraverse.
Ultraverse,
We can see the
which have markers for the on the catheter on the balloon, so we can actually
this
measuring
one,
measuring the length.
44, 44.
44
And
for right now. So
yeah,
and we will go push the balloon a little bit.
no, push
Uh,
the sheet, the sheet.
okay, we can remove the long sheath a little bit.
And I need another roadmap.
Roadmap. Okay, roadmap. So this is another way for measuring the size. Of course, if you have a technician for the DSA, they will measure it for you, which is also very good. But okay,
Okay.
44, and what's the number right now?
No. Because we pull back the sheet, so
Uh-huh.
we need
Remeasure it again. The balloon is actually relatively moving. So right now it's
53.
53.
And we pull back.
Pull back a little
back,
bit. 53. Put back to the opening of the internal iliac artery,
And
which
it is 44.
44. And I think that will be 9 centimeter, right? 9 centimeter. Um, so right now we are retrieving the this balloon, and we will forward the 8F sheath again.
Yeah.
So you can see that people when we moving around the sheath, especially for the 8F sheath, which is quite large and quite stiff in the iliac artery, which is for this case is severely calcified. We always using the dilation resembling the whole sheath and smoothly move it around. So just trying to avoid any perforation and some dissections for the medical source. So please give please give a lot of caution for doing this procedure when you're at home. Um, always considering about the safety first, because the iliac artery for our center, we have a lot of complications before, so that's quite important.
Okay. Okay. The root map.
Roadmap again. There we go.
Okay.
So, what's the diameter choosing of this case, Dr. Sun? What do you think about it? Should we choose a little bit bigger or a little bit smaller, and why is that?
I think maybe the predilation is not okay for this case because we think maybe the small pulses. So
Yes.
we direct go through the sheet and then we deploy the Viabahn and then we post dilation.
Post
As
dilation.
a bit of safety for rupture of the thrombosis.
Yes, perfect. I couldn't agree more. But for the diameter, what do you think? So before we, when we are measuring on a CTA, it's around like 9 millimeter.
No, 7.
7 millimeter.
7
Okay. So the blood vessel diameter is 8 millimeter around, right? So we are choosing a Viabahn for a little bit smaller. In this case, we can overlap a little bit for the internal iliac artery, and even though it doesn't matter, so because the size is a little bit smaller, so the blood can still flow into the internal iliac artery, but we can also covering the disease and opening the lumen. So that's another a little bit a small trick for treating this kind of cases, disease.
Okay. Open the Viabahn.
All right. Can we have the Viabahn?
Viabahn. Viabahn. 10, 10, 7, 10.
7 and 10. So it's a little bit smaller, and we are trying to locate the proximal and at the right about the sheath, right? That a little bit. So overlap a little bit for the internal iliac, but we are choosing smaller stent so the blood can still flow into. All right, we have 7, 10, and it doesn't matter. Just
okay,
open it. Yeah. There we go. Okay. All right. So you can see that different countries, again, I'm saying this again, I said it the last time. You can see that different countries, doctors from different countries have different ways to treating patients because they have different conditions. And I think probably just for the Western world, because they probably not considering much of the expense or money stuff for the patients because of the bloom are quite cheap in their country, and but the actual situation is not same here in China. So we have to always pre-evaluation before the operation for the patients. The expense, how many stand I'm planning to employ, and a lot of stuff. So this is quite different, I think, but it's uh, pretty good for the most of the world, because not everybody have the right instrument by their hand. So we can see that the Viabahn has already in place, and we will retrieve the long sheath. But before that, we have to give a little bit of dye to make sure again.
No. It's okay.
Okay, so
maybe
the distal is okay, right? Going back a little bit. Oh, going inside. Okay,
Yeah, yeah.
a little bit further.
Okay. This is okay.
Retrieve the long sheath. So using the sheath to protect the Viabahn, right? So make sure the Viabahn will not be wore off before you put it to the right place. All right. Okay, make sure again for the proximal landing zone.
Okay.
All right.
Okay.
A little bit more overlapping, but it doesn't matter because we are choosing smaller size of the Viabahn. So we can still, probably will still see some blood flow into the internal iliac artery.
So
Do you satisfied with this position, Dr. Sun?
no,
No,
no. I
not
will
yet.
be. Oh,
Double check again,
yeah,
right?
yeah.
Double check. So we are trying different angle and give a little bit dye again to make sure the position is right. Pull back a little bit.
Yeah, yeah.
So for this case, saving the internal iliac artery is actually the secondary goal for this one, right? So the primary goal is making sure the opening of the blood vessel to make sure to relieve the symptoms.
It's okay. Yeah.
All right.
Okay.
So if we have to cover the internal iliac artery, it doesn't matter.
Okay.
So going back to the RAO, we'll see RAO 24 degree to fully deploy the internal iliac artery, and we are making roadmap to locate the disease, and after that, probably we'll just deploy.
Open.
All right.
Slowly move.
Slowly deploy the Viabahn.
Okay. Slowly. Slowly. And a half. Okay.
Oh, there we go.
Okay.
So we can see the opening of the
No,
Viabahn.
no. Okay. Stop. And we'll see.
Okay.
We want to perceive the internal iliac
Okay.
artery.
Okay. So you will push in a little bit, right?
Yeah, yeah,
Uh huh. Do you see that, folks? Okay. So we deployed half of the Viabahn, and we gave a little bit of dye to see it to make sure that the position. And Dr.
Slowly,
Sun
and
is
we-
playing to when you're deploying the Viabahn, and also you are pushing the Viabahn inside, so you shorten the Viabahn, and you can preserve the internal iliac artery.
Okay. Slowly.
Slowly deploy
Yeah.
and also pushing in, pushing in, pushing in. You can actually see that the Viabahn is shortened a great deal. So for the road map, you can see the
Okay.
original place for the proximal place, and right
Okay.
now,
Very nice.
perfect, perfect,
Perfect.
perfect. Wonderful, wonderful,
And
wonderful. See, I told you guys, I learn every time. Tips and tricks every time. Perfect, beautiful. And next time, next step, we are trying for post dilation, right?
Yeah. Okay. 618. 680.
So
60 balloon.
so we're choosing 6 balloon first.
And
Also gradual post dilation,
yeah.
trying not to squeeze the thrombosis too much.
Yeah.
making sure there will not be the distal thrombosis occurred. So as we I think this the image for the Viabahn is actually reflecting the glide wire passing situation, right? Right at that place we have some resistance, and that probably the CTO disease right there.
Yes. Yes.
So you see that we don't use IVUS. We don't use IVUS for this case. We don't have a debulking methods for this case. We actually not using much of the wires, balloons, um, no fancy instrument, but we are still can treating patients very good, and so I think that's a lot. I think that's actually more educational for most of the world. That you can still using a relatively simple instrument to treating severely diseased patients.
I think IVUS maybe is right. It's good for the SFA or the PTK.
Uh huh.
But for iliac artery,
Uh huh.
I think maybe from the CT,
Uh huh.
CT angiography,
Uh huh.
and we can see the intersection.
Uh huh.
We can judge the
The
our
character of the
the
disease.
yeah the
Uh huh.
calcification process
Uh huh.
just like this,
Uh huh.
and we can also measure the diameter
Uh huh.
and the line.
Yes. So let me tell you folks again. So Dr. Sun actually passing this disease just using glide wire. I wouldn't say this, but for his age, when he was uh, back to the old time, he only got glide wire. So you don't have V18, you don't have points 14 wires, you just have glide wire. And if you can using glide wire properly, it can solve great deals of the problem.
So we use the 6 and 18
618
the
balloon for post
balloon.
dilation.
Yeah, and you can see the Viabahn maybe the 9
Yeah.
the 9 lines
And now it's we are shortening it to around 18, right?
yeah.
So that's a little bit of trick. You can actually push in Viabahn during the deploy.
8 8.
What's
Okay,
the
and
nominal?
okay.
Okay. Very interesting. Like I said before, I learn every time a little bit. Tips and tricks.
I think the location is good
Mm-hmm.
for press
Yes.
the internal
Uh-huh.
internal iliac artery.
Yeah.
I think maybe, and
Yeah.
we use the angiography to test.
Mm-hmm.
Okay.
Looks much better right now.
Yeah.
So let's. I think this is final angio.
Yeah.
Maybe perfect. Couldn't be better. So the internal iliac artery is preserved. The disease is covered, and the Viabahn, although we are choosing 100, but by using the little tricks for deploying, we are actually shortening it to the 80 millimeter. So let's see if we have any distal thrombosis occurred.
Yes.
And preserving those collaterals actually is very important. Still looking good. The deep femoral artery is still very good. And let's see the Pope. Oh, I think this is a disease for the SFA, right? The severe calcified part. We tried. We actually tried. but it's really hard to open it. If we wanted to successfully open it, I think we'll use the retrograde access to see if we can pass the fibrinosis cap. For the distal SFA, I think it's all right from the collateral, right?
Yeah.
Maybe one or two hard cycle, and you can see the dye going through to the SFA. After we opening the proximal iliac artery, it might be getting better. So here we go. Let's see the Pope. Oh, I think so, right?
Yeah.
Right?
It's okay.
It's all right.
It's
The collector is actually doing good job.
Yeah, I think it's good for the rest pen.
Yeah, yeah. It's definitely enough for the rest pain, and we are avoiding the over intervention for these patients.
It's fast, and we think we'll have the stent graft, and we are different. And it's Viabahn. It is the balloon expression stent graft, just like BD. BD and the Viabahn is the GAR.
Okay.
Also, but maybe I think it's here, the lungs. You know that the
if you are using blue expanded covered stand, you cannot stack it, right?
yeah.
But for Viabahn, you can always push in a little bit
Yeah.
and slowly, so you can adjust actually the size, the length of the stand. To be honest, I think it's fascinating. So you are choosing a little bit longer Viabahn and put it inside, and you see it's not actually very matching. So when you're deploying, you stack a little bit, and it's perfectly good. Fascinating.
And the Viabahn is soft.
It's very soft and flexible.
Oh yeah, flexible.
Flexible.
And the
And I have a question for you, Dr. Sun. Do you worry about the distal flow out for the Viabahn? Because you can see that the distal part is actually very close to the joint. Are you worrying about that for the further the longer patency rate?
Yes, but maybe we first cover the legend. So we must
So the primary goal is to cover the disease, right? And if it's a little bit of going into the joint area, which is fine, because you have to make sure the vessel open first, right? So do you have any special special the lifestyle for these patients? Do you have any other recommendations like you cannot for sitting too long or whatever? Do you worry about that, or is you can actually going like normal?
Yeah, this case the patients is 18.5
Uh-huh.
years old, so we don't need to open
Yeah,
surgery.
the older.
But for the younger patients, maybe we can
treat all the disease. That will be much better.
Yeah.
Okay. So do you so I see there's a little bit of stenosis for the right side for the iliac. Do you think is do you think is you have to treat that?
No.
No. Okay. So are we having questions on the internet?
Yeah, we do have two questions from the audience.
Okay.
I think the first question, Dr. Zhou, you explained this a little bit at the very beginning. Someone asked, for this kind of lesion, should we consider the use of plaque modification? Because you talk about this debarking for this kind of lesion is kind of risky. Can you talk more about this kind of plaque modification?
Debulking. Okay.
Yeah.
So back to the original question. Why don't you use debulking for the iliac artery, right? So for our center, for my own experience, for honestly, I do see one case that after using bare BMS for the iliac artery, and the artery is a perforation, and the patient died actually during the night. So it's for the severe calcified disease is quite risky. It's quite risky for the BMS. That's why at first we are choosing the covered stent. That's the first place. The second place is also for the iliac artery is always stenosis, CTO disease, and accompanied by thrombosis. It's always. I don't know the literature reporting the rate, but for our experience, it's always like that. So using covered stent is much safe for the distal thrombosis. Thrombosis. The third one is for the debulking method for the iliac artery. It's still the same for the safety first. If you are debulking and the patient is severely calcified, it probably making the perforation, which is very bad for us. You can have to you have to either emergency you can deploy the covered stent, or you have to go in open for the open surgery. And for this kind of age, 85 years old gentleman, you are going open surgery, which is actually killing him, right? So what's the next question?
Okay, I know for this kind of lesion, it's kind of risky to do the deparking. But what if, if you have to do the plaque modification or deparking, what kind of device you may try to decrease the risk of perforation?
So they want to know how do you reduce the risk if you have to using debulking.
Yeah, that's the question.
Maybe we use the large sheet first, and then with the open the stent graft on the table. So we can use the you can see this picture. We can see the guidelines past the lesions. It's very hot in the middle. So we think maybe it's the stenosis or maybe the occlusion. For the packing, just like a strap, we can see maybe the up is good for this thrombosis.
Yeah.
But in here, will
the
be the
CTO
rupture.
disease is not
Will
okay.
be the rupture.
So actually, if for the safety by using debulking, first you have to pre-evaluate the size of the vessel. So if the patient's vessel is too small, you definitely cannot use the debulking methods. Like Dr. Sun just mentioned, when the glide wire passing that stenosis part, that's definitely the narrow part. So if you are using debulking, avoiding to debulk that part. So if you are doing debulking for that part, CTO part, probably making perforation. So you can do proximal part, you can do it for the distal part, but trying to avoid that stenosis part. So in that case, sometimes you are hard to determine which part is which part. So for the safety, we are just trying to avoid debulking. Do we use debulking for iliac artery before? Yes, I think the answer is yes, definitely. We used that before, but
you need the rupture.
yes, we are also taking a lot of risk.
Another debulking is for the CDT. CDT we can use, but this patient is 85.
Yes.
85 years old, and maybe the blood rest.
We can also leave a catheter there for thrombosis. So we will leave a catheter there and get patient back to the ward and perfusing some medicine for a while, like 3 or 5 days, maximum 5 days. And we can go in up again, do the angio again, see if the lesion is shortened. For most of the patients during the past experience, the lesion did shorten.
Yeah.
And we can, for this time, we're probably using a 100 millimeter stent. But if you are doing CDT, we're probably using half of the size, half of the length stenting. We can solve the problem. But for this kind of patient, 85 years old, which is really senior patients, you are leaving a catheter inside the patient's body, and you have to doing the insulinization for like 3 or 5 days, and it's a lot of risk for the bleeding, especially intracranial bleeding. So we're trying to avoid that. We're trying to do it one stop. to solve the problem.
Another question?
Yeah, the second question, Professor Liu invented a software to do the 3D reconstruction of the coronary arteries. I don't know if you have seen that kind of image or not. The
No.
audience, oh, that's kind of pity. Maybe they want to know. I know before this procedure, you have done some pre-evaluation. You did the CT angiography. So, because this is severe stenosis, sometimes you may see a situ lesion in iliac artery. So, except for the CT angiography, is there any other assessments to evaluate this kind of lesion?
Unfortunately, for our department right now, we only have CTA. And after using CTA for so many years, like 10 years, 15 years,
More than 10 years.
more than 10 years, for using CTA for the pre-operation evaluation, we are actually good at it. We are actually good at it. So CTA is very important. You can see the different characters of the disease, calcification, the low density plaque, the other kind of plaque or dissection, whatever. You can actually see everything. And after that, we will combine with medical history, right?
Yeah,
medical history is very important.
Yeah.
And there's also some lab parameter like D-dimers, and if it's D-dimer is increased, significantly increased, so we probably considering about the thrombosis stuff. So it's never just the one single factor to determine what's the strategy next. It's always different things combined together to making decision. So, like you said, the software probably will be good, but right now for us, we are not using it. But if there's a chance, we will use it later.
Okay.
So I saw some of your live broadcast for the cardiology department. You can see actually the plaque. You can see the calcification using different colors. You can remove actually part of it, right? So maybe it's good.
Yeah, it's a very fancy technology.
Yeah, I know.
They appreciate lots of information to make your decision how to treat this kind of lesion.
Yeah, I know.
Yeah.
And
there's another question, because how about the use of intravascular imaging for those kind of lesion, like AVAS or OCT? Do you have any experience doing this kind of imaging tests?
Using IVAS for the iliac artery. To be honest, we don't have the experience, and we are trying to show you the actual working situation for us in this department for now. This is our daily work, people. This is our daily work. We are doing this every day. We are not like using fancy stuff, fancy technology, fancy instrument, or IVAS every day. Because, like I said before, different patients in different countries have different conditions. I think Western world doctors, they don't have to evaluate too much about the expense.
Yes.
You can just pull on everything you have and just do it, and you will get perfect results. But for us, it's not the same. We have to pre-evaluate it precisely, and how many stents I want to put in, how many balloons I will use, if we have to use debulking methods, because everything is connected with money.
Yeah.
We have to explain it to the patients. We have to let the patients accept the plan. And if the patient don't accept, we have to change to another plan. So it's to be honest, it's quite hard for us being a doctor doing this procedure. I will be plain. I will be frank. I will be just say what we have right now. This is actually the everyday work we are doing for every day.
I agree with you. Just do whatever you can with the current devices available in
Yes,
the app.
yes.
But the thing is, about the coronary interventions, maybe 10 years ago, we didn't use the imaging test very often. But right now, almost every case before the treatments, we use the intravascular imaging to give us some guidance. So what do you think of the future of the imaging test, for the peripheral intervention in the future?
So, what do you think about the future of IVAS?
IVAS is okay for the SFA or the PTK lesson, but in the iliac lesson, I don't think so because the stand in the iliac artery, the first preparation, the petition is very good. So we think for the iliac artery, I think the iris is not it's not necessary.
Necessary.
Necessary
Okay, so
for
you
this
don't have to
patient.
use that. You can
Yeah.
also you don't have to use IVUS to guide you. And you can still finish the job.
Yeah.
And but for SFA and Pope, it's probably different, right? So using IVUS to decide
The different dependency in the different part of the iliac and
Okay.
SFA and the BTK.
Okay.
But I think the iliac has a wing, just like PTS, or the iris is okay.
Okay, so for the venal disease.
The venal disease.
Okay.
I
And
think maybe the AAA is okay. I don't know.
AAA. Yeah, I do see some people using IVUS for AAA.
Yeah, you see?
For like infrarenal or junctional renal, which is pretty complex. You're trying to selection different branches. So they might be using that for the aortic. But you are talking about the patency for the iliac artery. So because the patency for iliac artery is actually pretty good, better than the SFA and the Pope.
Yeah.
So no matter if you have an IVUS, you just put in a stent in, and it can last for quite a long time.
Yeah.
But SFA and the popliteal is quite different. You have to plan it carefully. You have to decide carefully. You have to see it's very accurate and to make your final decision to either doing DCB or using stent or actually just the debulking is good enough. So I think basically the Dr. Sun's meaning is it's all depend on patency. So for these patients, probably after we put in the Viabahn here, he can last for a really long time, even you don't use the IVUS. But for if we will successfully pass the disease for the SFA, we definitely should use IVUS to see the actual situation in there, right?
Yeah. I think maybe in the future I use more and more IVUS, the SFA and the BTK. But the OCT, I don't know which here is okay.
OCT. Yeah, I have no idea. Do you have Dr. Lee for the OCT?
The different OCT and the IVUS.
You know, compared with the IVUS, OCT has a much better resolution. But the pagination of the OCT is not as good as IVUS. So maybe.
Oh.
Right. Can you hear me?
Yeah.
Yeah. But the thing is, maybe for some small vessels, OCT is better than IVUS. But if the vessel diameter is kind of big, IVUS is definitely better than OCT.
So IVUS can see bigger, right?
Yeah, you're right. Right. And also, let's get back to these patients because there's still severe stenosis in SFA. So are you going to treat that lesion in the future, or are you just going to follow up the patients and then decide whether or not you are going to treat that lesion?
We are definitely treating follow-up right now. Because collateral, you can see for the angio later on, the collateral is very good. They're very good. And after you open the proximal iliac artery, you can see the from the collateral, the popliteal and the BTK arteries actually doing good. They are doing good. So based on our experience, if you are opening the proximal arteries, it can definitely relieve the symptoms. Okay. So, but if the patients actually have a Rutherford 5 or 6, 5 or 6, which has gangrene or ulcer on the foot, we definitely recommend opening the iliac artery and SFA, because it will help for the healing, you know. But right now, this patient only have rest pain, so we think iliac artery is good enough, and we can cut in the budget. We can cut in the intervention, and we can solve the problem.
All right.
There we go.
Personally, I also have a question about this procedure because if we put a stents, so usually we give the dual antiplatelet therapy for 1 year, and then we may stop the use of clopidogrel and use aspirin for the lifetime. So how about for the peripheral intervention? After the cover stent implanted in these patients, so how long are you going to use the dual antiplatelet therapy?
Actually, we are kind of a little bit different for the guidelines compared with cardiology. For the lower limb, we are the current guideline is trying to recommending using single antiplatelet and anticoagulation. So single anticoagulation plus single antiplatelet and stattin
For how long?
for
Well,
forever.
For lifetime?
Yeah.
One antiplatelet therapy
At-
plus one
at-
anticoagulation for lifetime.
at least um, 6 months.
At least 6
At
months.
least 6 months.
Uh-huh.
And the aspirin for lifetime.
For lifetime. Yeah.
Uh-huh. So what do you think of the use of clopidogrel?
I think there's a higher risk for clopidogrel resistance. So for our department, we're choosing aspirin first.
You prefer to use aspirin?
Yeah.
Okay.
Yeah.
Okay.
All right.
And
So, Dr. Sun, I think we are very close to the end of this transmission. So before we finish this procedure, I think the audience wants you to make a summary of this, patient, this procedure. Anything the audience can
I go?
take back
Okay.
home? Yeah.
So
the profile.
I will say choosing the right plan for different patients. Choosing the right plan, not one plan for everyone.
Yeah.
That's the first one. The second one is choosing the right instrument for different lesion. So for the iliac, definitely using covered stent is much safer than any other stuff. And debulking have a great risk, and you have to use it with great caution. And other than that, I think we are good, right? Yeah, I think we are good.
All right. Okay. Thank you.
Thank you
guys,
so much.
deserve a round of applause. Thank you so much for your
Thank
efforts.
you. Thank you. Thank you for the